Hi, in this lecture we will discuss how to manage a case of extrusion and lateral luxation of teeth. Those of you who've come to this channel for the first time, do subscribe to it to receive continuous updates. And now let's go ahead with the lecture. Extrusion is a condition in which the acute impact forces the tooth out of its socket. So in this case, clinically, the extruded tooth is displaced out of its socket, hence it appears to be elongated like this. You can see it appears to be hanging down. At the same time, this tooth is mobile. It is mobile because it is being held in place by a very few intact gingival fibers palatally. And radiographically, you can see increased periodontal ligament space is visible. I will explain with help of a case. In this case, there is extruded left central incisor and an avulsed lateral incisor. Now, when the mobility was checked of the central incisor, it was discovered that it is very mobile. It can be moved in horizontal as well as axial direction. And then percussion test was done. It revealed that there was slight tenderness on percussion and a dull percussion tone was observed. Next, pulp testing was done and it was observed that the tooth did not respond to the pulp test. It gave a negative response. Now, once this clinical examination was over, then radiograph was taken. On radiographic examination, it was revealed that there is coronal displacement of the tooth. Now, if you observe the position of this root apex and compare it with the position of this root apex, you can see that the involved tooth has displaced coronally. Once our clinical and radiographic examination is over, we have a fairly good idea about the situation of the tooth. So our next step is going to be to reposition this extruded incisor. Now how do? We do this by slowly and gradually applying apical pressure here in this direction with help of this finger. Now when we apply this pressure, we gradually displace the coagulum formed between the root apex and the floor of the socket, as this tooth will move apically. Once the tooth is repositioned, we apply acid etch on the involved tooth and the adjacent tooth. As shown, we use orthophosphoric acid gel and we etch it for 10 to 15 seconds. It is then washed with water and dried. This is followed by applying bonding agent and then composite. If this composite is then cured, after that the excess composite is removed, especially in the gingival area, using a straight scalpel. Now this composite is smoothened using abrasive discs. At this point, it is very important to note that there should be no composite obstructing the gingival area and affecting the oral hygiene procedures. Once the stabilization has been achieved, then the gingival wound present here is closed with help of interrupted silk sutures. We take a final radiograph and the radiograph reveals that the tooth has been repositioned nicely. So far, we have repositioned the extruded tooth and we have fixed it or stabilized it with help of a composite splint. Our next step is to check the occlusion to make sure that there is no pressure on the involved tooth. The splint that we have used, we use it for about 2 weeks. Now, during this time, the vitality of the involved tooth is monitored. What happens is gradually we start receiving a positive response and soon the tooth starts responding normally. However, in some cases, what happens is you can receive false negative even up till 3 months. So this is how you manage a case of extrusion of the tooth. I hope you have followed it. Coming to lateral luxation. In this condition, a horizontal impact forces the crown palatally and the apex labially. The clinical picture presented is that of tooth being displaced and immobile. That means this tooth, it gets locked in the fractured alveolar processes. And when we percuss this tooth on the incisal edge, you will hear high metallic sound. There is fracture of the alveolar bone. You can see that. And when we do pulp testing, we invariably get a negative response. The first step in treatment is to anesthetize the affected area. Now for anesthesia, we use infraorbital block. The technique for this involves the use of 25 to 27 gauge long needle. The area of insertion is the mucobuccal fold directly above the first premolar here. Now the target area is the infraorbital foramen. You can see it is marked on the skull. The landmarks, they include the mucobuccal fold, the infraorbital notch and the infraorbital foramen. Orientation of the bevel is always towards the bone. Now to anesthetize the palatal tissues, we use the nasopalatine block. Now the nasopalatine nerve, we know it innervates the palatal tissues of the 6 anterior teeth from here till here. Now this is the entire area which is covered by the nasopalatine nerve. Now the technique for this is we use short or ultra short needle and we insert it in an area which is lateral to the incisive papilla. Now this is the incisive papilla. It is present in the midline just behind the central incisors. So we will insert it somewhere here which is lateral to the incisive papilla. And the angle of insertion, we insert it at 45-degree angle with the orientation of the bevel towards the palatal tissue. In the first picture, we see that the root apex has been displaced labally after fracturing the alveolar bone. Now, to reposition it, we apply finger pressure and force the displaced apex to break this labial lock and to disengage the root. Next, we apply axial pressure and will bring the tooth back to its original position. So this is how we reposition a laterally luxated tooth. The next step is to check the occlusion, and then radiographs are taken to verify adequate repositioning. Then splinting is done. It can be done with composite using any of the two methods that have been shown in the pictures. Now this splinting is held in place for 2 to 3 weeks. Then radiographic examination is conducted. Now if this radiographic examination reveals no sign of marginal breakdown, then the splint can be removed. Otherwise, we might have to use further controls. Complications arise if on radiographic examination we see inflammatory resorption of the bone or the root, like this, as depicted in this X-ray. Now in such a situation, what we have to do is we have to go in for immediate endodontic therapy or root canal of the involved tooth. That was all in this lecture. I hope you enjoyed it. Do subscribe to this channel and share it with your friends. Also check out other videos on tooth trauma and the videos on dental caries and occlusion. Thank you.